My name is Sarah Westwell, and I'm a consultant clinical oncologist at University Hospital Sussex in Brighton. And I've been invited here today to speak with you about the COVID-19 pandemic, the lessons learned, and the impact on patient care from the Brighton experience. Before I start, I just want to thank Imogen and the team at Melanoma Focus for inviting me here to speak with you at your patient conference. I feel immensely honoured and privileged to have an opportunity to speak with you and to speak along my esteemed colleagues. Here are my disclosures. So I just want you to roll back your memories to the beginning of wave 1 of the COVID pandemic in February and March 2020. I'm sure you will recall that we knew very little about COVID or about what was about to happen. However, we were in receipt of long and continuous news feeds from the media depicting large numbers of very sick patients requiring intensive care as a consequence of COVID infection in China and then latterly in Italy. We recognise that given the potential high levels of infection that were anticipated and the significant numbers of patients that were likely to require intensive care, that there were risks to the NHS and the NHS's ability to provide emergency care, let alone provide elective planned care for patients with cancer. So in identifying the risks to our cancer population, we understood that there was likely to be a reduction in the outpatient, inpatient diagnostic and treatment capacity as a consequence of reduced staffing levels from our staff needing to self-isolate in the early days when we did not have access to swabbing when they developed symptoms suggestive of COVID, through sickness as our staff developed COVID infections themselves, and also through our staff having clinical vulnerabilities and needing to shield. We recognise that our patients were competing with the COVID priorities within the NHS resources, and there was an inevitable repurposing of estate, redeployment of workforce, and reallocation of resources to support the COVID pathways. You will recall that anaesthetists were redeployed from theatres where they provide elective surgical care to support the expansion of the ITU. Theatre and recovery estate was repurposed to provide ITU, and many of our nursing staff, even within the cancer department with experience in emergency medicine and ITU, were redeployed, as were some of our junior doctors. We acknowledge, though, that the skill set for our clinical consultant workforce was best reserved to support our cancer population. We acknowledge that there would be delays to presentations of patients with malignancy, and we recognise that there would be missed opportunities. Although I have to say that I don't think any of us truly predicted the enormity or the numbers of patients that haven't presented over the last 18 months with malignancy. This was as a consequence of patient fear and reluctance to seek medical help, but also a change in the delivery of primary care as that moved online, and there was a significant focus to support COVID. There were also concerns about the symptoms of COVID mimicking progressive cancer or the toxicities of treatment, and therefore patients being assumed to have COVID and managed at home without clinical review when in fact they had an alternative diagnosis. And I certainly experienced this on at least one occasion when I recall in April undertaking a virtual consultations with one of my young high-risk patients who described a 5-week history of a progressive cough, breathlessness and fever. He had spoken with his GP on numerous occasions. The paramedics had delivered twice, and there was a presumptive diagnosis of COVID, and he was managed at home. Speaking with him, I was very concerned that he developed relapsed melanoma, and we organised an emergency admission that day to hospital, and a CT scan later that day confirmed he developed relapsed melanoma, and he was COVID-19 negative. There was also concerns about the risks of severe COVID-19 illness and mortality for our cancer patients. And at the beginning of the pandemic, there was a real absence of data. The only real data we had was in relation to a small number of patients from China. And there was an assumption that COVID-19 infection in patients receiving systemic anti-cancer therapy were at high risk of morbidity and high risk of death as a consequence of COVID infection. This, in fact, was not borne out in the data collected in the UK throughout the first wave of the pandemic. We also recognised that we needed to balance the risks and benefits of treatment with the risks of COVID infection. COVID superimposed a whole new layer of risk-benefit considerations that we'd not had to previously consider, and we knew very little about the true risks of COVID, albeit we knew a lot from our clinical trials and evidence base about the risks and benefits of treatment in the non-COVID world. So this immediately had the potential for COVID to negatively impact patient care and experience before we even started to modify and develop our services. We've already acknowledged the potential for delays and deferrals in diagnosis and treatment, and I would refer to cancer as the forgotten C during the COVID pandemic. We acknowledged that there would be, or there was some inevitable stopping of treatment prematurely, or a omission of doses, and the delays to presentation and access to treatment and investigations has the potential for a negative impact on our patients in terms of their outcome from cancer. Patients experience a significant amount of fear and worry and anxiety in relation to fear of exposure to and infection from COVID and the potential outcomes, and a separate fear driven as a consequence of cancellation or delays to investigations and treatments, and the fear that this would have a resultant adverse effect on outcomes in terms of cancer. There was also isolation and loneliness amongst our patient population. Patients were required to attend for consultations, investigations and treatment without the support that they were used to and entitled to. And this added another level of anxiety and fear. They were isolated from family and friends as a consequence of the advice to shield and as a consequence of lockdown. And for some, there were difficulties in accessing food and medicines and social and medical support and care. I worry that for some, there was a poor or inadequate symptom control as a consequence of reduction in face-to-face reviews in primary care and with community palliative care services. And I think there are also lost opportunities, those opportunities for lived memories and experiences for individuals with life-limiting disease due to shielding and lockdown. So the goals of care for our cancer patients during the COVID-19 pandemic were primarily to maintain cancer services whilst protecting patients and staff from exposure to COVID and infection from COVID, whilst delivering safe, individualised, high-quality, evidence-based melanoma treatment balanced against the risk posed by COVID infection. I think it was apparent we needed to maintain communication within teams, between teams, and with patients and their carers, and this in itself posed problems, and to support patient and staff well-being. So how did we go about providing a COVID-secure environment? Primarily, it was about reducing hospital footfall in the early days before we had the ability to segregate patients and surveillance swab our patients and staff with access to PPE. So from an outpatient perspective, as the majority of our care is provided in the outpatient setting, we developed a hybrid outpatient clinic model of care, offering patients a variety of face-to-face, video and telephone consultations, which we adapted according to patient need. I'm a huge fan of video consultations. I think it gives you an opportunity to observe your patients. As a clinician, I gain a great deal of clinical information from observing patients that I feel can sometimes be lost on simple telephone calls. And I find it easier to build rapport with patients when I'm able to see them and observe non-verbal cues. Video consultations, though, also gave an additional ability for us to provide support for patients. So we were able to undertake three-way video consultations and bring in relatives who may either be in the same street but in a different house and unable to visit, or in a different country or in a different part of the UK. And even now, as we return to more face-to-face consultations, we sometimes use video calls to invite distant family members in other parts of the country in our face-to-face consultations. I think we needed to think about pre-treatment choice, scheduling and delivery. So the selection of treatment, we wanted to minimise toxicities requiring admission to hospital. We considered the use of oral versus intravenous preparations. Oral preparations meant what am I trying to say? Oral preparations meant that patients needed to visit hospital less frequently, whereas intravenous preparations results in patients attending the hospital to receive treatment. There are also the concerns about toxicities being confused with COVID-19 infection, for example, immunotherapy-related pneumonitis or BRAF/MEK inhibitor targeted therapy-related fevers. And the risks that patients may be reviewed in COVID areas in the emergency department inappropriately in the early days when we were unable to swab at home. There was then the scheduling of treatment cycles. So, for example, many patients may have been receiving 2, 3 or 4 weekly scheduling of treatment, and we moved on to the longer 6 weekly scheduling of treatment for the majority of immunotherapy patients, and for those patients receiving oral targeted therapies, for those that were stable on treatment, we prolonged the prescription dispensing 2 months at a time. For some patients, we deferred or omitted cycles of treatment or stopped treatment a few cycles prematurely. So, for example, our more clinically vulnerable patients who would have been at high risk of significant morbidity or mortality from COVID infection, who'd either experienced a good response to immunotherapy and it was very reasonable to stop treatment early, or who were nearing the end of adjuvant treatment. And for some patients, we decided to omit treatment at times of high COVID local infection rates where we were concerned that the risk of exposure to COVID was too great. We also moved to remote dispensing of oral drugs, and we posted and couriered these medications to patients' homes to avoid them visiting the hospital and exposure to COVID. We also adapted the way we provided assessments for patients and emergency care. We undertook pre-treatment assessments from our nursing staff 24 hours ahead of patients attending the unit. We opened a new 7-day, 12-hour acute cancer assessment unit, which we had not had the privilege of having prior to the COVID pandemic, and we opened this 3 weeks after lockdown. And this was to provide specialist care and assessment for patients with cancer and receiving treatment for cancer, and to avoid the need for them to attend the emergency department. We've also launched an ambulatory immunotherapy toxicity service, again to provide specialist immunotherapy toxicity support for patients experiencing toxicity in the ambulatory setting to avoid hospital admission. We've enhanced our patient education for patient-centered management of BRAF/MEK inhibitor toxicity, namely around the management of febrile episodes, again to avoid the inappropriate attendance at the emergency department and the risk of exposure to COVID. We developed a febrile patient pathway advising patients to call our patient helpline rather than 111 to ensure they had specialist advice. And we enhanced our treatment and general helplines with follow-up and support, again to avoid unnecessary admission to the emergency department. We modified our surveillance imaging plans, so we utilised the independent sector to provide clean COVID-free hubs. We changed the way we surveyed the brain and switched to CT in place of MRI, as this could be done at the same time as imaging of the body. We stratified our image follow-up. For example, patients that had experienced a complete radiological response to first-line immunotherapy where we knew the risk of developing recurrent disease was low, we stretched out the intervals between imaging. And for those patients that were considered high risk for severe morbidity and mortality from COVID infection during periods of high local COVID infection rates, we deferred and drew out the interval of surveillance imaging. We were early adopters of surveillance COVID-19 swabbing for both patients and staff to ensure that we could provide a COVID-safe environment, and we were quick to roll out vaccination across our staff and clinically extremely vulnerable patients. We also adopted a compassionate visiting model to provide for our carers of our patients. Whilst many trusts stopped visitors altogether, we planned for visitors to support our patients. So we reduced the numbers of patients waiting in our department, but we did not stop it altogether. And we also utilised things like the car park for patients to wait in their cars rather than the waiting room. We called them on their mobiles to invite them into the department. And we had the luxury of being able to use our sister Horizon Centre, which the Macmillan team very kindly donated to us to use for patient waiting space during the pandemic. So lessons learned. I don't know about the lessons learned. I think COVID has highlighted lots of fragilities and vulnerabilities across the NHS. And I think what COVID really did was confirm the importance of. So I think COVID confirmed the importance of maintaining those essential services for our cancer patients. So access to diagnostics, treatment and support, and access to clinical trials. It confirmed the importance of communication. So making informed decisions about patients with patients. It confirms the importance of communication around the provision of care and support for patients and for each other, and maintaining regular contact, and about providing rapid access to reliable, up-to-date information through accessible platforms for our patients. Patients were hungry for information. There was a dearth of information. Advice and guidance was changing at speed, and patients were ringing the telephones off the hook, and due to redeployment and reduced numbers of staff, we in the early days were unable to keep up with the demand in answering the phones. So we very quickly developed online information. It's confirmed the importance of team working and collaboration. So departmental redeployment rather than redeployment across the trust. So we redeployed across our cancer teams rather than cross-trust teams. We had regular team huddles to ensure that we kept lines of communication and support open within teams and were able to easily hand over. We had close collaboration with primary care and community palliative care, and I think this is really important for the future. And national collaborations to develop treatment protocols and pathways and data collection for the outcomes of our cancer patients. We streamlined and individualised delivery of care through the hybrid outpatient model of care, and I would encourage us to keep this so that we don't routinely bring all patients up to clinic when they don't need to visit clinic, and delivering treatments closer to home is preferable. We've developed new ways of working and flexible. We need to work flexibly and develop or demonstrate agility to respond to changing circumstances. We've developed pre-clinic multidisciplinary weekly tumour board meetings to discuss patient care and management decisions, and we're diversifying our workforce. And I think it goes to say that staff wellbeing and patient wellbeing is hugely important. Happy, well staff provide a good care for patients and improve outcomes for patients. So, what are the positive impacts for COVID for our patients? Communication, improvements to and a commitment to continue to provide high quality, up-to-date information. Improvements in access to clinical nurse specialists and support workers and emergency helpline advice. Improvement in an access to a specialist team. So the development of larger, I suppose, Sussex-wide multidisciplinary virtual teams so that we have resilience in our teams to move to provide the care required. Improvement in access to specialist unplanned care with the ambulatory immunotherapy toxicity service and the ambulatory assessment unit, both of which are huge positive additions to our provision of care. The personalised delivery of care, so the hybrid model of outpatient care and agile delivery of medications delivered closer to home. And the ultimate drivers to separate elective from emergency care to protect planned cancer care via community diagnostic hubs and surgical hubs. Thank you for listening. I look forward to discussing after the remainder of the talks. Thank you.